a brief history of how I got here. I graduated in '87 and started doing general dentistry. Didn't do a residency, just came out, started doing general dentistry. And slowly along the way began to, like you guys, you take seminars, you begin to learn things. There's certain things you like or don't like. Approximately 26 years ago, one of my sons was born. We moved into a house. He developed asthma very quickly. We moved, and we found out the house had mold in it. 6 months later, we moved out, but the damage was done. Took him to an ENT, and the ENT was very quick to have a discussion with me. He was a young guy, and we had a discussion about airways and breathing and the importance of airways. And so he pointed me to a book that I read, and it had to do with facial development. And that kind of led me down the path of orthodontics. So took some coursework, started learning how to do functional appliances, palate expanders, transverse appliances like Herbst appliances to help motivate the lower jaw forward, Mara appliances, same type of thing too. And then from there, we kind of just started placing brackets. Invisalign came out in the late 90s, and they wouldn't let general dentists in, but then slowly they did. And I started doing Invisalign cases. And you'll hear me talk a lot about them tonight. And I give them a lot of credit for where they've brought us. But you're also going to hear that this particular company, 3D Predict, has taken it to a much higher level. So Invisalign, we started cases with them right away because it seemed like it was something that we could all benefit from. And adult patients do not want to put brackets on, obviously. So quickly we realized that by the 7th or 8th aligner, most of the cases were derailing. They were not tracking well. And so we would take new impressions, because we didn't have scanners back then. We would take new impressions and send them in, and back and forth we'd go. And after 4 or 5 tries, we would kind of give up. I quit Invisalign and I stuck to brackets and braces. It was predictable. The orthodontists in the area were helpful with me, but adult patients didn't really want to go down that path. And this is, in the early 2000s. So I got out of it and then jumped back into Invisalign because supposedly it was new and improved, and it was better. It really did. They grew a lot, but it was not where it could be. So I once again have slowly drifted away from Invisalign, and that's how I got introduced to 3D Predict. The salesman walked in, we started talking, and right away he was speaking my language. Tonight, what we're going to talk about, if I could boil it down to 2 words, it's torque control. And I don't want to talk over anyone's head, but it's the ability to manipulate roots, especially in the lingual or palatal direction. All aligner companies are great at one thing. They're tipping. They're tipping machines. They will tip teeth wherever you want to tip them. And so most of the time, that is not the most desirable movement for teeth, because anyone that we've all studied anatomy, we know that on the buccal surface of most roots is very little bone. And when you start tipping into that area, you can do far more harm than good. So what 3D Predict does better than anyone is they eliminate that with their, if you're using a CBCT, and if not, they now have a lot of data through AI to limit or minimize what we call recessions. Because if you tip a tooth too far buccally, what are you going to have? You're going to have recession. And we say gingival recession, but honestly, it's partition. The bone recedes and then the gum just follows it. So that's me. We don't need to look at that. So I actually wanted these 2 slides separate. So if you look at the slide on the left, this is a relapse case. This is an adult case, not mine. It's a relapse case. I would say that anyone in this room would treat this case through Invisalign, and we would find it to be a simple case to treat. And you would, for the most part, upright and fix some of the angulation, but you would tip the teeth and kind of procline them or move them out into the buccal space. The image on the right is where teeth exist right now. Now, if you look at the picture on the left, you would not imagine that there is that much bone missing. So to look at that picture, the red means there's about 1 millimeter thickness in bone. The white means there's no bone. You're looking at root surface on those anterior teeth. That's where that picture is from. Those are the same people at the same time. If you were to take this case and put it into any other aligner system and tip it in the buccal direction, you will have catastrophe. You're already starting with a problem. I wouldn't touch this case, not without a periodontist and periodontal work. And this is not a case that you would want to tip in the buccal direction at all for obvious reasons. So what 3D Predict does is it tells you where you start, and it will give you a great map and predictability as to where you want to go. Oh, wrong button. So like Sasha said, there's two ways to go. One is on the left here without a CBCT, and then the other one is with a CBC. Our office has one. CBCT is vital. We do implants and other work that we need it for, but I wouldn't consider treating an orthodontic case without it, simply because you just don't know what you have. And this is some of the lesser important things. Sometimes there's things like sinus floors and other things, structures you can't get past, root collisions that might occur without it. So what we're going to talk about tonight is expansion in the buccal direction, and it is possible when the bone is available, and that's what we're going to talk about. So this picture is talking about center of rotation. To make it real simple, if you were going to take just one point, your fingertip, and push it on that root, where would you push it to get the whole root to move vertically? Well, without knowing exactly how long the roots are, you wouldn't know exactly. So there's a center of rotation. If you push it too far to the incisal, you're going to get tipping in one direction. If you push it too far to the apical, you're going to get the root move and not the crown. So knowing where that center of rotation is important. And so that's why I would recommend, at very least, a panoramic X-ray to know, are we dealing with really long roots, short roots, blunted roots? Those are things you should know. But that's what this picture. So we take an average of approximately where we should be pushing and how the torque is going to be involved in moving these teeth. This is just it again. What it's showing there is most aligners, if you move them, you're going to get tipping, simply because they don't have the ability to control the root. And the way that 3D Predict controls the root is not only with their attachments, but more importantly, with the design of their tray. Their tray is not scalloped. And a scalloped tray sounds like a good idea, and that's what Invisalign uses. The problem with a scalloped tray is that it doesn't deflect the root lingually or palatally. It itself deflects, so you get very little root torque with an Invisalign-like tray. I don't care how thick they make their material. If there's flexing in the material, and there is, what's going to flex is the tray and not so much the root. So 3D Predict's tray manufacture and design controls root torque in a very important way. These are just slides that show that you can get bodily movement. Sometimes bodily movement is not only desired, you need that. Sometimes tipping is what you need. And it depends on the case. It's very case specific. That's why I like to submit all my cases with a CBCT, because you get a better idea of when you need to bodily move and when tipping is more advantageous. And that's what these particular pictures are showing. And in some cases, adjacent teeth, some will be tipped and some will be torqued or moved in more of a bodily way. And that's what this shows once again. 3D Predict, how many here are using Invisalign? How many are doing clear aligners? Any company? 3D Predict? Okay. So most clear aligners, if you watch the root tips here, you'll see what happens. Some of them are going to move and some are not. The ones that don't typically are the teeth are just tipping. But in certain areas, you're going to see bodily movement. You can see how the crown and root are. Does this have a pointer? No. Okay. So once again, it's the same slide. I backed up. Moving teeth with brackets and braces is very predictable because in the bracket itself is the torque and tip of the tooth. And as long as the bracket's put on the right spot, the tooth's going to move. That's what all aligner companies are attempting to do. They're attempting to make their movements predictable. The reason that most Invisalign cases require 3, 4, 5 refinements is because the tray is not getting the tooth to the desired position, and therefore you end up with these refinements to get to where you want to go. Once again, these are just showing that. So I think the average refinement number for Invisalign is around 4, 3 to 4. It depends whose study you look at and all that. But this is internal. This is an internal study done by 3D Predict. Out of 94 patients, 83 of them had expansion without refinements, which means, and I probably, they're about 1 or less than 1 refinement per case. Now, from a chair time perspective or from just an efficiency perspective, obviously that's important. If you're using Invisalign, I did hundreds of cases with Invisalign, and the average was 3 to 4 cases for me with refinements, at which point most of the patients were getting tired of it and they just didn't want to go any further, and they were tapping out. And I understood that. So we get them mostly there, and maybe we were both okay. But the reason for the refinements is simple. There's no control over roots. They can tip, but if you can't control the root, you're not going to get the tooth where you want it to go. So it's pretty impressive that 88% of the patients in 3D Predict are getting full expression of their expansion without refinements. This is once again just another example of it. So average, and most of these cases, most of my cases are in the 14 to 16 range. Now, a lot of my cases, especially the younger patients, we will do more distalization of molars to unravel the anterior if that is appropriate. I don't like to do IPR on young people, so I tend to do less and less of it. And so those cases might take a little bit longer, but an average adult case like this is 6 months, 9 months, you're finished. And in tracking these cases, they track very well. We'll see patients every 2 months. We'll give them 4 trays. When we see them at the 2-month time, we pop the new tray and it snaps in. The patients are tracking well with the trays. So from a standpoint of chair time, they're in and out of the office in 2 minutes. The girls are very efficient. My staff, they know how to handle it, and very rarely do we have refinements that we have to deal with. This is more of the same. So what you're seeing on the top right is those purple are not attachments, they're actually pressure points. And what 3D Predict does is Invisalign scallops their trays, right? So 3D Predict doesn't. Their trays go about 1 millimeter beyond the gingiva and go from tooth to tooth. What that does is it gives a lot more anchorage. It's almost like a banding or a strap that prevents the tray from being deflected buccally, but rather it will express it will be fully expressed in the root. And when you see those purple pressure points, what it's doing is it's controlling the root rather than just tipping teeth buckle. It's tipping, but it maybe is maintaining the root where it is, or it's moving the root in a lateral lingual direction, which is really very important. You can see them on the middle where the roots actually move. Getting that kind of expression in that lower picture from a tray is next to impossible. And as far as I know, 3D Predict is the only company that's getting that done. And if you look at the picture on the right, is that moving? That should be. No. Well, yeah, it is. Okay. So if you look at the red house, what we try and do in all our cases, and what the technicians, what their goal is to create a better periodontal situations, to create buccal bone or to get the root away from that 1 millimeter of buccal bone that exists in, in a lot of situations, a significant number. But what's happening, especially the one on the top, is we try and go from red, which is about a millimeter of bone thickness, is really what we call bundle bone. It's just plate. It's not, there's no trabeculation there. And if you move that in the buccal direction, it'll dehisce very quickly. By moving it palatally, you will get bone because the buccal plate's going to stay where it is. So you will get bone in there, but no, we're not growing bone along the necks of the teeth. Every single case is looked at and designed by an orthodontist, every case. So, and they use AI for it. So AI is used in many areas, right? It gives us more information. It tells us if you do this, that may happen. And that's where AI is going to come into play with a particular case, a company like 3D Predict. Have you used Invisalign's new 3D controls with their CBCT? Okay. That's a good question. So we did, we were very active in Invisalign. When I started drifting away from it, my sales rep was very adamant about me staying with it. And I kept telling them, well, this is like about 2.5 years ago. It's just not predictable. And I don't know where the roots are going. And I do all my own surgeries. I know when I open up a flap, there's never any buccal bone. He says, oh, we're going to come up with it. So finally, about 1.5 years ago, they did. And he showed up at my door and he says, I want you to run a case. I said, okay. So I put a case in and the technicians didn't know what to do with it. I said, so all it will show you in their bone model, which is that model, not the model on the far right, they'll show you in the root model. It'll show you where you're getting dehiscence and fenestrations. It will not do anything with it. You've got to go in and either manually move them or write in the script, please move the root, tip the root palatally 4 degrees to whatever it's going to be. The other problem is this. So their tray design is inadequate and their attachments are worse. Before I started with 3D Predict, I had dropped all their optimized attachments and I was using rectangular attachments because in my mind, as a general dentist who placed brackets were great. You stuck them on the tooth. You could do anything you wanted with that tooth. A rectangular bracket or a rectangular attachment will give you that. 3D Predict uses 2 brackets. They use a vertical rectangle to move a tooth horizontally, and they use horizontal to move them vertically. It just absolutely makes sense. So we'll go through treatment where maybe 8 trays in, we're taking some attachments off and putting new ones on because we've moved the tooth vertically, horizontally where we wanted to put it. Now we want to move it vertically or vice versa, whatever it might be. Invisalign doesn't have the text yet, nor, in my opinion, the tray design, nor the attachment design to express torque control. They don't have it. And honestly, 3 guys came in from Costa Rica. They sat in my office and I told them the exact same thing. I said, you're never going to get it with what you have. I said, your tray will have to be literally rock hard because if not, what's deflecting is not the root, but the tray. You're getting some, you might get 10% expression, but they're not getting any more than that. And I don't want to be in a system where I can see the dehiscence and now I have to start going in and playing with every root. So I think they're kind of onto something, but they're not even close yet. And they don't need to be. The 800-pound gorilla in the room, they do what they want. So these are a couple of my cases. And I'll talk more about it, but a lot of what I do now in 3D Predict is we do a fair amount of it, but a lot of it is sold not because people want straight teeth. They do. But when we start talking to them about recessions, about misplaced teeth, they had orthodontics and now the roots are beginning, we're getting recession, abfractions, wear facets, poor canine or anterior guidance. We're doing more of that. We're doing more 3D Predict for that. And of course, people want straight teeth. But when they hear the health benefits to it, the periodontal health benefits, especially older people. Young people, it's all about the looks. As you get older, it becomes more about function. So your 45-year-olds, they're like, yeah, looks are important, but it's more important that I have my teeth the rest of my life. So more people are doing it for that. This is one particular case, nothing overly complicated about it, but complicated enough so that Invisalign would never have handled it. Now you can see this patient's already in need of gingival surgery. She's gonna get grafts at some point down the road when everything settles down. We'll do some gingival grafts. This was a relatively short 5-month, like I said before. Most are treated in that 6 to 9 month period of time. She starts with some crowding, some rotations, lateral rotations. Number 10, they're the most, that's number 7 rather. They're the most challenging to do. Anyone that tries to move a lateral tooth, they never want to go. They don't like to rotate, and they definitely don't like to erupt. So this was the movement we predicted. Now, I know that there isn't any aligner company that can give you root movement, and they can tip teeth. There's no question, but that's usually not the answer, and that's usually not what's desirable. I think we'll look back in 10 years at orthodontics and say, how were we moving teeth without knowing where we were moving them? What was the thought behind that? And if you talk to the periodontists, they do a ton of periodontal work, from blown out adult cases that were overexpanded, because everybody gets an expander today. I don't think that's appropriate treatment, but there's a lot of expansion that happens in orthodontic practices. And it's probably expansion beyond what the periodontium can handle. So you have to work within the bony housing that's there. Just like I wouldn't put an implant in today without a CBCT, I would not do orthodontic treatment without a CBCT, or at least a company like 3D that knows this and is going to use their AI to give you the best case scenario. And there, once again, it's just showing how we improve the situation and on as many teeth as we can. And there's some situations where there's just no bone, lower anterior, as you know, and sometimes it's just buccal and lingual plate. There's not a lot you can do. But once again, you don't want to start tipping those teeth into a spot and cause a bigger problem. Like I said, these are everyday cases that walk in. These are simple cases. These are easy to treat. There are so many of these in your practice. There's at least 4 or 5 a month that are sitting in your practice that are easy. People want to get them done, especially younger girls in their 30s and all. You know, they're going for Botox in their 20s. They want to get their teeth straightened. Men sometimes, yeah, it's a little bit more challenging to sell a guy on something that's like that. But if you once again, if a guy walks in and he's got these level of recessions, I'm not talking to him about straightening his teeth. I'm talking to him about where he's going to be in 15 years. Because if you don't do something, you're going to have a bigger periodontal problem in 15 years. Now that they're on board with. So once again, this isn't for 3D Predict. This is very predictable, very easy, very straightforward, and very little time involved. You scan, you take your photographs, you send it in, they develop it. If the CBCT, you send that in with it. What comes back is a guide. You put your attachments on, it takes 15 minutes, and out the door they go. I see them every 2 months just because I don't trust people and I want to kind of remotivate them and just kind of give them a little motivation every couple of months. And so I'll see them every 2 months. But I know guys that just give them a whole box of trays and say, I'll see you when you're done. I like to have them in the game. I want to see them every couple of months. but that's seeing them as I walk in, say hi, how are you kids, how's everything going, snap the tray and back out. Just 2 minutes, I'm in and out. So it's very little time is involved, and it's truly life-changing for a lot of people. So, of course, really, we call it expansion, and it's bodily movement of a tooth and root and torque control. True expansion, when you talk to an orthodontist, true expansion, they're talking about palatal expansion. We're not talking about that here. That's a different thing. We do it different times, usually in younger people, because most adults are not going to tolerate a palatal expander. But if you look at this one, look at the control of roots. That to me is so important, because a lot of times in Invisalign, you don't know what's happening to the roots. And so if you have root collision, teeth are not going to move. And it's kind of dangerous. If you force them, you can get resorption. And it can be tracked back to you, and there's an issue. So knowing where the roots are is vitally important in these cases. And we have, there's plenty of cases that walk in where you can see the lower molars are dumped in lingually. Older cases, extraction cases, quite common. And so a lot of those patients have apnea and breathing issues, and a lot of them were mouth breathers, and they may still be. So cases like that, you usually have a constricted palate. You do the best you can in a situation like that. You upright the molars, you get as much bodily expansion on the upper molars, and you create a slightly wider garage for the patient to park their tongue in. That's the best you can do. You're obviously not going to expand the lower jaw. That's just not possible. And this is just, once again, giving you a view of the roots. Translating canine roots 4 or 5 millimeters in a lingual direction is extremely difficult, but these guys get it done. Those are just some of the numbers. Number 7, the rotation was huge. That was big, because laterals just don't move. They're very challenging to move. But everyone sitting here has 5 of these cases in their office a month, minimum 5 a month. So it can be a very profitable thing. And then once you start doing it, you begin to realize there's a lot of patients that could benefit from adult orthodontics, not just from the aesthetic standpoint, but from a periodontal health standpoint. This was a second case. She was to orthodontists. No, she was to 2 general dentists that sent her to orthodontists, and the orthodontist said, you're really not going to close those spaces successfully with Invisalign, because that's what they did. And they were right. You aren't going to close it with Invisalign. With Invisalign, you can retract them lingually, you can tip them, but you're not going to get bodily movement. And to me, that was important for this girl. And when I said, I know we can do it, and you need it, because she's going to get almost a full mouth of gingival grafts. This is, I think, how old? 32. She's a young girl. So we're finished with her. You'll see the finished pictures in a minute. And if you like to do gingival surgery, there you go. as I've progressed as a dentist treating orthodontic cases, my number one thing is canine guidance, unless it's a big class 2 case, in which case we're not going to get it. They're going to have an overjet, period, unless they want to wear class 2 elastics for 2 years, and people don't want to do that. So I don't even present that. Most people are okay with a big overbite. They want other things fixed. So if I can fix that, I'm going to do that. But I could never distalize molars with Invisalign. I would them. And sometimes, you got those molars that have a little mesial lean. You're like, okay, I can lift that up, but you open the bite when you do that. If you do this, you don't open the bite, but if you do this, you're opening the bite. Now you have another issue that I manage. And yes. Yes, it does take 3. It takes forever. But you can upright or you can distalize. Uprighting still takes 3 years. But now that I can distalize molars a couple of millimeters without a problem, I can get that canine relationship where I want it. I can eliminate the IPR. Yeah, it takes an extra 4 or 5 months to do. But if you explain that to a patient, they're okay with it. They understand it. People, let's face it, if nothing, the internet has made people very savvy on a lot of things. And they understand what a bite is, and they understand why they need a good bite. They might not be able to explain it to you, but when you explain it to them, they accept it and they want it. So that's kind of how you'll evolve as you do these things. You start doing these cases, you're going to look deeper into, where do I want to finish this case? Do I just want to take what the orthodontist has given me? And quite honestly, half the time I do, the other half the time, I'm either moving it myself with their 3D controls, because they have 3D controls like Invisalign does, or a lot of times it's just easier for me to just say, look, distalize both molar segments, left and right, 2 millimeters, and unravel the anterior into that space, and give me canine guidance as close as you can get it. So sometimes canine guidance, the tooth is here, and there's, the lower canine maybe needs to be uprighted just a little bit, not tipped, but uprighted. And when you do that, you can get what you're looking for. So that's one of the things that this company is allowed to do as a general dentist, to give a better, more effective treatment plan that is not going to cause a different problem. So obviously with this case, it was important that we move teeth in a lingual direction as much as possible. She had tremendous recession on many teeth, and we did not want to exacerbate that problem in any way. So you can see how much red disappears and how important that is, especially in this. So it reappears on the lingual, but lingual recessions are much easier to manage and much less detrimental. Buccal recessions happen fast, and they're permanent. We're not growing buccal bone. Best we can do is put gingiva back. Once you can see the amount of improvement on the periodontium. And this was the finished case. And you can see once again, her lower, she's got spaces there, but she had she had spaces up top. So the gingival embrasures that were opened up, she had no problem with. And if she did, I probably would bond those with a matrix. I would bond those spaces. I wouldn't recommend for her to do more orthodontic treatment and further because to do that, you can't collapse those teeth anymore lingually. Now you have to start pulling everything from the posterior forward, and you're looking at another 6 to 9 months of treatment. And she definitely wasn't in for that. But they didn't seem to bother her one bit. And you can see even some of the reactive lesion on her lateral here, lower lateral. So she's got gingival issues, and whether or not I or a periodontist, I probably would ask the periodontist to handle this case. That's a lot of soft tissue work. I finished most of my cases with a fixed lingual and oftentimes with a clear aligner over that. Not always, but quite often. And the reason for it is for at least a year or two, I want to make sure that that it stabilizes and it's in good shape. I finished one a friend of mine's wife with just a lower bar, and I use a lot of NTIs if I feel it's appropriate as a retainer. We didn't do a full arch NTI. We did an anterior NTI. She relapsed, and we had to retreat her and open her back up again. So I've since moved to lower bar. I'll use an upper bar too if there's room for it. But I'm not a fan of them because they tend to get beat up easily. And some kind of a Vivera type full retainer. So we had a good result with her. She was very happy also. That's just the amount of movement we had with it. Once again, for a lower, number 24 to have 18 degrees of movement is beyond, beyond anything anyone else is going to do. 18 degrees of rotation is very challenging. Oh, and this was, so this was a third case where, I don't know if this was I forget which case this is, but what it's showing you is our initial CBCT, where we wanted to get to is the 3D plan on the far end and where we are on our progress. It's almost exactly spot on. And so they're using a lot of these post CBCTs to just verify that the roots, I don't take them because it's, giving the patient more radiation, they don't necessarily need that. So I don't typically take them, but when we do, we find that the tracking of the roots is very, very close to what we predicted they would be. The crowns are easy. You can move the crowns around. That's relatively easy. It's where are the roots going? And it was unilateral expansion, which is also, it's challenging to do with any aligner system, but to get just a one side of expansion is challenging. So this just goes, and I kind of briefly talked about it before. I did a lot of Invisalign, hundreds of cases, and the average was probably 4 refinements. So every time it's a refinement, where I typically will remove the attachments, new scans, place new attachments. It's a lot of work. I have to do that. My staff can't do that. They can put the attachments on, and they do a phenomenal job with it. But taking them off and scanning, it's all chair time. I would have to say after a while, I felt like I was losing money with Invisalign. If it happens, if any case that you have to touch an Invisalign 3 or 4 times, there's no way you're making money on it. Your profit per visit drops like a brick. And we just, we put some numbers up that are close, but certainly what I have found in the cases I've treated with 3D Predict is half the cases, there's no refinement. Maybe other half the cases, we're getting maybe 4 or 5 trays just to tweak things. Quite honestly, sometimes patients want me to move things, and I'm like, okay, if you say so. They paid me, and I want to make them happy. And I look and I'm thinking, well, we're barely moving that tooth, but if it's going to make you happy, then we'll go ahead and do it. And a lot of times, people show up with their little mirrors, 10x, and they're looking this close, and you have to make people happy. So we'll do that. But most of the time, we're within 95% of where we want to be in our 3D Predict cases. And since I've obviously stopped using Invisalign altogether, I don't use it at all. This is just an explanation. Like we all restore someplace implants. And I like to say how productive and how profitable implants are. I wish I could agree. They're not. They're profitable, but there's challenges with implants. If I were going to go down one path today as a younger dentist, it would not be to become a great implantologist. It would be to become a great ortho guy or girl. That's what I would do. because it's more predictable. On some levels, it's more fun because you're really changing things, and it's a lot less stressful. Moving teeth is easy. Putting implants is hard. It's a lot of work, and things go sideways, and when they do, it costs money. So, I mean, this slide, the takeaway on this slide is it's very predictable and very profitable to be doing these orthodontic cases. There's tons of people out, and we live in an area. You know, I'm in New Jersey in a very affluent community. People in this area, New York, they want nice teeth. They're not walking around with crooked teeth. You can provide a service and at the same time increase their periodontal health, and that's very important. And I spoke a little bit about this before, how I consult with patients. I mean, we have plenty of moms that bring their kids to us and we treat them. My philosophy is I treat phase 1 up to about age 9 or 10. We do expanders when needed, and no, everyone doesn't get them. A lot of kids have a class 2 relationship. We give them different, there's a couple of cemented appliances we use, Mara and a Herbst, that'll move the lower jaw forward. They're on for about a year. They're pretty easy to use. They come off and I tell the parent, I'll see them when they're 15. I don't want to do anything else to that child because I've seen so much decay, orthodontic related decay, that if it were my own kids, that's how, I mean, we treat our patients the way we would treat our own family members. My own kids would not get braces at the age of 8, 9, 10, take them off when they're 13, and then start filling cavities when they're 16, and then treat them again because they didn't treat the second molars anyway. My philosophy has become phase 1 gets done. It's very easy. There's plenty of courses out there that'll teach you how to do phase 1, how to read a Ceph. You don't have to be a genius, how to read a Ceph, and how to treat phase 1. And then you treat phase 2 when the patient is old enough to handle aligners. And so that's how I handle teenagers. And when I talk to the parents about that, they agree 100% that they don't understand why their friends' kids are getting braces at 8, 9, and 10. I don't understand it either. Well, I do understand it. I think it's more from a financial perspective than anything else. And it gets expensive. They treat phase 1, they put them in braces, then sometimes there's a second round of braces. That's kids. Adults, once again, they want straight teeth, but it's more important that we fix their bites, their malocclusions, and their bite-related gingival situations, all the abfractions, all the recessions, all the blown out relapsed ortho cases. Those cases have to be treated, and they have to be treated in a way that's going to be beneficial to the patient, not just straightening teeth, but keeping in mind that a lot of previous ortho was done with excessive expansion. Maybe not in this area, but I know where I practice, there's way too much expansion going on, not only with expanders, but then with these nickel titanium arch wires that's given everyone this excessively wide smile. And no, not everyone can have one. Not everyone looks good with them. And you've seen those cases where they're very canine prominent, and you can see teeth beyond that. They're too wide. If and when those cases relapse, you have to take a CBCT and you have to move them in a palatal direction. Because if you try and move them in a buccal direction, you're gonna create more problems. So that's my consultation with adults. They get it, they understand periodontal health. Our office, like most offices, we're periodontal driven. We talk to them about soft tissue therapy and all that when it's needed, but we also talk to them, we show them with a mirror and intraoral camera what their gums look like and why certain things might be happening. And they're very on board with it. That's it. Extrusion. Extrusion is still a challenge. It's a challenge for everybody, but 3D Predict does it because of anchorage. See, I said before how their aligner is designed differently. Their aligner has a lot more anchorage. And to extrude a tooth, you need anchorage. To intrude a tooth, you need anchorage also. Most intrusion is not a true intrusion. most of the time the teeth are intruded because we will torque them. And so you're getting 2-3 millimeters of intrusion, which is more desirable most of the time. Extrusion on laterals, yes, with a horizontal attachment and the proper anchorage, the proper tray design, you can get. Most of these cases are coming in deep bite cases. What you really want, you want this to happen. You want intrusion. Now, you're not getting a lot of root intrusion. What you're getting is this torquing, and that torquing will give you an opening of 3-4 millimeters, several millimeters. You can get a couple of millimeters per arch easily, so you could completely collapse case. And all of a sudden now it's got maybe 3 millimeters or 2 millimeters of overbite, as opposed to 7 or 8 or 9 millimeters, which is very detrimental to the lower teeth. And you show people, look at your lower teeth they're all chipped and they're broken, and part of the problem is you have a very deep bite. What do we do to fix that? Well, you fix the bite, and you can fix it with 3D Predict. You cannot fix it with Invisalign. I tried dozens of cases and I gave up on it. It's not going to happen. I wish it did. If it did happen, I wouldn't be standing here tonight. I'd be standing in front of an audience talking about Invisalign.
But time-wise, how much longer does it take to extrude posterior?
Extrude the posterior, you can get extrusion in about 4 months. Yeah, 8 to 10 trays, you can get them up a couple of millimeters. And that's all you're looking for, is at 2 millimeters per arch. You get 2 millimeters per arch. I mean, 4 millimeters of extrusion total is a lot. And if you take that and intrude the lowers and the uppers, get your proper inner incisal angle, then you've created a desirable bite. Now you can do whatever you want aesthetically. You can put laminates, you can put things without worrying, are they going to break this stuff? Well, they're going to break it. They are going to break it. If you got a deep bite, things break. So, okay. Thank you guys for coming out. I appreciate it. I really do. Thank you.